Let's walk through this case of a diabetic female who presents with abdominal pain and low-grade pyrexia. Right from the history, we know diabetes is a key player here, especially when poorly controlled, as it predisposes the patient to more serious complications such as infections. But we need to figure out exactly what's happening here. We begin with the ultrasound findings. The right kidney is clearly enlarged, measuring 15 centimeters, quite significant. Looking closely at the parenchyma, there's a loss of corticomedullary differentiation. This typically signals ongoing damage or inflammation. What catches my attention even more are the small echogenic foci scattered throughout the renal tissue. These are interesting because they don't cast acoustic shadows, which rules out typical renal stones, but they suggest something more unusual might be going on, perhaps gas within the renal parenchyma. Given the clinical context of a diabetic with abdominal pain, this raises some red flags. We move to the CT scan for further clarification. Now, the CT images tell us a more detailed story. The right kidney is again notably enlarged, especially at the lower pole, where we see a low-density area, likely a collection of fluid. But what's more concerning are the multiple gas locules scattered not only within the renal parenchyma, but also in the perinephric space. This combination of gas and fluid is alarming because it suggests an infectious process that has progressed to involve surrounding tissues. Additionally, there's no hydronephrosis, which means there isn't an obstruction to urine flow causing these findings. Next, let's start piecing together some differential diagnoses. Based on the gas within the renal tissue, one possibility could be gas-forming renal abscesses, but that's less common unless there is severe infection. Another differential could be a severe form of pyelonephritis complicated by gas formation, possibly emphysematous pyelonephritis, EPN, which fits this patient's profile much better given her history of diabetes. Let's delve a bit deeper into emphysematous pyelonephritis. This is a rare but life-threatening condition, typically occurring in diabetic patients like our own. It can also arise in patients with immunosuppression or those with urinary obstructions. Escherichia coli is usually the main culprit here, followed by Klebsiella and other organisms like Proteus and Pseudomonas. The infection is so severe that it leads to gas formation within the renal parenchyma and sometimes the perinephric tissues, which is exactly what we're seeing on this CT. Looking at the findings, this case fits well within the Huang classification of emphysematous pyelonephritis. It appears to fall into class 3A or 3B, where gas has extended into the perinephric space and possibly beyond Gerota's fascia. This stage is serious and requires aggressive treatment. Now let's confirm the diagnosis based on these findings. Emphysematous pyelonephritis with renal and perinephric abscess formation. The patient is dealing with a necrotizing infection that has involved the renal tissue and extended into the surrounding space. This condition has a high mortality rate, especially in diabetics, if not treated promptly. In terms of management, this patient needs immediate hospitalization and IV antibiotics. Controlling her diabetes is crucial here to stabilize her condition. However, given the gas and fluid collections, medical management alone won't be enough. She will need percutaneous drainage of the abscess under CT guidance to remove the infected material. If there's no improvement, surgical drainage or even nephrectomy might be necessary. Discussion around emphysematous pyelonephritis often centers on its association with diabetes and the presence of gas-forming organisms. The mortality risk is incredibly high without intervention. We can use the findings from imaging modalities to guide treatment. Plain films can show gas in the renal beds or along Gerota's fascia, while ultrasound can reveal echogenic foci representing gas in the kidney. But CT is the gold standard for diagnosis. It not only shows the extent of the gas formation and fluid collections, but also helps guide treatment like percutaneous drainage. The gas bubbles and fluid levels seen on the CT here are typical hallmarks of emphysematous pyelonephritis. Let's also highlight an additional case involving obstructive pyelonephritis, where a patient presented with bilateral staghorn calculi leading to urinary sepsis. Imaging revealed a large calculus obstructing the renal pelvis, which resulted in severe hydronephrosis. Despite full medical management in the ICU, the clinical course didn't improve, emphasizing how crucial early intervention and surgical management can be in such severe cases. Ultimately, timely diagnosis and management are critical in cases like these. If you found this case study insightful and want to learn more, subscribe to Radiology Made Easy on YouTube. Feel free to share your thoughts or ask any questions in the comments, and let's keep these discussions going.